Next speaker is Dr. Nauman Naseer. He's working as professor of cardiology, and he'll talk about FFR techniques. Thank you very much.
So I was asked to give a talk on practical tips and tricks involving the FFR, IFR, coronary lesion assessment, and we're going to go over that. This concept of coronary physiology has been around since 1979 when a paper was published by Grunzig et al. In NEJM, where they dilated coronary lesions, and once they decreased the stenosis, they measured pressure gradients across the lesions after decrease in stenosis, and the pressure gradients went down. But it's only 2 decades later that FFR was put to clinical use after the deferred trial. And what is FFR? In simple terms, all that you need to do for all practical purposes is maximal achievable flow as achieved by maximal exercise or maximal hyperemia that is directly proportional to the myocardial perfusion pressure, that is hyperemic distal coronary pressure. Flow is equal to pressure change divided by resistance. We all know from our physics days. So we have to assume the resistance in the microvascular blood and venous pressure is 0. And if you assume that, then the formula that we are left with is FFR is equal to PD over PA. And if that value is less than 0.8, that's considered significant based on our studies done with nuclear imaging and stress imaging, showing ischemia in lesions where FFR is less than 0.8. Now with this new non-hyperemic pressure-based index of severity is IFR, which is calculated by measuring the resting pressure gradient across a coronary lesion during the wave-free portion of diastole, when microvascular resistance is low and stable. And this measures the physiologic impact of a coronary lesion on the distal coronary bed. A value of 0.89 is considered significant, and there are 2 recent large randomized trials which have fully validated IFR against FFR, and this has become now routine clinical use, and because of which there have been sudden uptick in the use of pressure wire for coronary lesion assessment, because you don't have to give any drugs for hyperemia. So this is nicely illustrated over here, that you have a catheter tip which is measuring the proximal pressure, the wire transducer is measuring the distal pressure, and P distal versus P aortic in maximal hyperemic state is FFR. And IFR is in the wave-free period in diastole. You measure that in a resting state, and that is IFR. PDPA is just measuring the whole pressure during resting phase. And values of FFR 0.8, IFR 0.89, and PDPA, anytime you insert the wire across the lesion, if you're getting ideally it should be 1 if there's no gradient, but if it's 0.91 without any hyperemia, you know that lesion is going to be significant. So now this is just pictures taken by the phone from our tech who shared with me in the cath lab. So we use a volcano system. This is the, actually, pointer ka kya hisab kitab hai? We use the volcano system. So I guess so nazar nahi aaya, so volcano system we use, and you can see the 0.014 wire, which is a regular wire. It's just not as steerable as the regular wires. And you can see the console of the volcano system, which is a pressure wire and IVUS over there. And this is what comes out of the packaging. So this is what comes out of the packaging, the plastic tubing. You put it down on the table, flush that plastic tubing, let it sit there for 60 seconds, then hand over this cable, plug it in to the console, and the machine will say, it's not showing up over here, that will start saying by itself, wait for zeroing. Sometimes you press the 0 button, but over here in this console, it says wait for zeroing. Then it will say zeroed and ready to insert. So you're going to use the insertion tool, advance the wire to the guide catheter tip, and this is where the radiopaque marker, this area, the proximal part of the radiopaque marker is where the pressure transducer is. You're going to bring that part of the wire to the guide catheter tip, and then you're going to plan to normalize or equalize. But I've specifically showed this insertion tool. A lot of people make the mistake when they press the normalize button, they haven't taken the insertion tool out. Take that insertion tool out, flush with normal saline, because you leave the contrast and your pressures are going to be damped. So you flush with normal saline, take the insertion tool out, and then press the normalize button. And before you're doing all this, pressures, make sure your transducer heights, all those were okay, and you're zeroed properly to get the accurate reading. Those are the important steps to keep in mind. Then, this is after that, you're going to cross the lesion with a wire, and then you can do your IFR, FFR measurements. This is a gentleman who kept coming back with equivocal chest pain. Stress test was non-diagnostics. We did an IFR, FFR. It was significant. We stented the LAD. So just going over the steps, just a reminder of the steps. Important point, the steps that I didn't mention over here was pull back. Then when you're done with the FFR, IFR measurement, pull the wire back to the guide catheter tip and check for drift. There is inherent thing in the wire because of temporal and temperature mediated, that the pressure starts to fall down from the transducer of the wire. So you want to make sure the pressures are still equalized after your FFR measurements, and you want to pull the wire back to the guide catheter tip. If they're not equalized, you have to advance the wire back and do the measurements again. So how do you achieve hyperemia? Now with the IFR, you won't really need to do, but you can, I still, with the IFR to verify, do FFR as well using hyperemia. Use the same dose as you would do as a nuclear imaging stress test, that is 140 micrograms a minute adenosine dose. And after 2 minutes, you start seeing full effect with dyspnea, hypertension, in a few cases, AV block as well. Intracoronary dose, what dose to use? There are a lot of papers from 10 micrograms to up to 700 micrograms dose used. I use 50 micrograms for right coronary artery and 100 micrograms for the left coronary artery. And if you get the desired effect, that is FFR is significant, then you don't need to give any more. But I'll increase in incremental fashion, but I never go beyond 100 for the right or 200 for the left. After that, I'll stop. If you need, then you should use intravenous, because otherwise a lot of these showed pictures of AV block with adenosines and stuff, you can get all those side effects. So pitfalls that you need to remember, common ones: wedging, whipping, drifting. So what is wedging? If you put your guide catheter and engage it really deep, you're going to have wedging. And as a result of the wedging, as you can see, there are ventricularized pressures over there. So the FFR was 0.9. But when you reposition your guide and got a proper aortic tracing, your FFR is 0.79. So you need to watch out for that the guide is not wedged when you're doing a measurement. Then what about whipping? If your wire tip is in a small branch and the transducer is hitting against the vessel wall, that's going to create the whipping artifact. So you need to reposition the wire, get rid of the whipping artifact before you do your measurement. Then what is gradient versus drift? Remember, whenever you're going to have pressures from the wire tip, most of the time you're not going to see a typical dichrotic notch as you see from the aortic pressure tracing. This is the drift area, and this is where you're getting true gradient. And this is an example of somebody with drift. So you did the measurements, FFR is 0.78. But again, whenever you do measurements, after that, pull the wire back to the guide catheter tip. There should be equal pressures. That's where you equalized. But there was clearly the wire transducer pressures were lower, so you were not getting reliable reading. The pressures had drifted. So equalized again, did the measurements again, and the FFR was actually 0.85. And now you pulled back after equalization, the pressure is still equal. So this is the more reliable reading. So this was a case of a lady who recently presented just 1 week ago to me with ACS, non-STEMI, EF of 45%. She had two different opinions. She was told to just she had Wellens-Stevens stent in the LED and forget about the rest. She's 70 years old. And somebody also told her, get a cabbage. So they wanted, what should we do? There's a question mark about left main. It looks maybe significant, maybe not. Also osteal with the left circumflex. My just humble suggestion to all of you is whenever you're committing somebody to left circumflex intervention or bypass, make sure that it's significant. So what I did was I did IFR of the left circumflex or left main to left circumflex IFR. That is significant, 0.81, 0.89 is the cutoff. And for LED, we knew it's going to be significant, but the LED lesion was clearly, proximal lesion was clearly tight. So I did a mini cone crush technique. This is the results in the left main, distal, and in the proximal LED. So this is another example of osteal left circumflex over here. You can take all the orthogonal views you want, but you probably will not be able to tell if it's tight or not. So put a pressure wire down if it's significant over here, 0.52. You need to, the patient has real symptoms. Now in multivessel coronary artery disease also, this is clearly tight, you know that. But what about the other lesions? Should we fix it, not fix it? It's very helpful that you do pressure wire guided PCIs. The literature has also shown better outcomes with that. So left circumflex was clearly going to be significant, but RC also, look at this, 0.53, because the territory it was supplying was much bigger. So it's also not just dependent on the degree of stenosis, but the territory it supplies. LED pressure wire was not significant, and RC after stenting, the pressure wire improved. You want it to be more than 0.9. Now in the West and over here also in the cath lab will start offering that, the co-registration system. You do the FFR, and then, you can see on the angiogram where the gradients are changing. And where you get the maximum gradient, you stent that area, and especially in diffuse disease, that can be very helpful feature. Special scenarios to remember, aortosteal lesions, disengage the guide, remember that which I showed. For left main, as I showed in that case, assess both LED and left circumflex, and make sure you pull back pressures. And the CTO donor vessel FFR, I just had a case recently with borderline LED lesion, 60% right RCO was a CTO. So I did a FFR of the LED, it was 0.78. And after fixing the right CTO, I did the FFR again with the LED, it went up to 0.83. So didn't need to do the LED because it's dependent not on the degree of stenosis, on the area it supplies. And if you have discrepancy between rest and hyperkinesis, then you use your clinical judgment. Can't use for vein graft. ACS culprit lesions, you can use it in non-culprit. There's a lot of data. Dynami, Primulti, a lot of trials which have shown that severe congestive heart failure. We assume the venous pressure is 0. So, you can't use it in severe congestive heart failure patients. I will skip through the trials for the sake of time. The time is up. These are all the trials which validated the use of FFR. This was FFR-guided PCI versus medical therapy in coronary artery disease, where it showed that if you have FFR-guided revascularization, those patients did much better, as in shown in the green line versus in the blue line versus the red line, where the people did worse if their FFR was significant and they were treated medically. So this was out of the COURAGE trial. So if you properly document ischemia in these patients, they did much worse based on urgent revascularization if you did not get revascularization after a significant FFR. And IFR has been well validated by defined flare and then Sweetheart trial in terms of that is as good as FFR in terms of clinical outcomes. Always a side branch. 1/4 of the side branches which look more than 75% actually are 70% of them are not significant based on FFR. So you can leave most of the side branches alone. So guidelines based on all these trials have given class 1 indication to use of FFR, IFR, and class 3 indication if your FFR is not significant. And remember, the value of experience is not seeing much, but seeing wisely. Thank you.